Everyone experiences trauma at some point in their lives, and most of the time, with support from loved ones, people are able to recover. But in individuals with trauma and stressor related disorders, like post traumatic stress disorder, these experiences lead to symptoms like flashbacks and nightmares, as well as hypervigilance and aggressiveness, all of which can profoundly impact their life in a negative way. Trauma and stressor related disorders are thought to be caused by a combination of genetics, biological factors, and environmental factors. The genetic link is based on the fact that those with a family history of mental issues tend to develop the disorders more frequently. Biological factors include high levels of stress hormones like adrenaline and cortisol, even in the absence of stressful situations. Environmental factors include things like family neglect in early childhood or jobs with high trauma exposure like being a firefighter or a soldier. That's because repeated trauma increases the risk of trauma and stressor-related conditions. Trauma can be thought of as an overwhelming amount of stress that exceeds one's ability to cope or process the emotions involved with that experience. A traumatic event can involve one or repeated experiences over time. For example, the experiences include things like serious road accidents, poverty, neglect in early childhood, military combat, and sexual abuse. Psychological distress following a traumatic event most commonly causes anhedonia, or lost interest in activities that were once enjoyable and a decreased ability to feel pleasure. It can also lead to dysphoria or a profound state of unease or dissatisfaction, externalized anger or aggression, and dissociative symptoms like detachment from reality or self. Most individuals develop depression, anxiety, and have problems with substance abuse, which is often a way to self-medicate symptoms. For diagnosis, the symptoms should cause distress and prevent individuals from functioning properly in all areas of life, including at school, work, and in social situations. According to the DSM-5, the group includes 7 conditions: post-traumatic stress disorder or PTSD, acute stress disorder, adjustment disorders, reactive attachment disorder, disinhibited social engagement disorder, and the last 2 are other specified and unspecified trauma and stressor-related disorder diagnoses, which are reserved for symptoms that don't fit any of the main sleep disorders. In PTSD, the symptoms all relate back to the traumatic experience. First, individuals must have either directly experienced a traumatic event, witnessed it in person as it happened to others, only heard about it but it involved a close family member or friend, or they must have experienced repeated or extreme exposure to graphic details of traumatic events, like police officers or paramedics. Second, individuals should present one or more of the following 5 intrusion symptoms: recurrent, involuntary, and intrusive memories of the experience, nightmares, dissociative reactions like flashbacks where individuals relive the event, intense psychological distress when exposed to mental or physical reminders, and psychological reactions like sweating and heart palpitations when exposed to trauma-related reminders. Third, there should be avoidance behavior, where the individuals either try to avoid internal reminders of the trauma, like distressing memories, thoughts, or feelings, or they try to avoid external reminders by avoiding people, places, or conversations. Fourth, individuals should experience negative alterations in thinking and mood associated with the event. The alterations should be evidenced by 2 or more of the following 7 symptoms: inability to remember important aspects of the event due to dissociative amnesia, exaggerated negative beliefs about oneself, others, or the world, like thinking the world is completely dangerous and no one can be trusted, distorted thoughts about the cause or consequences of the trauma, which leads to individuals blaming themselves or others, persistent negative emotions like fear, horror, or shame, diminished interest in daily activities, feelings of detachment or estrangement from others, and anhedonia. Lastly, individuals must present with alterations in wakefulness and reactivity, as evidenced by 2 or more of the following 6 features: irritable mood and angry outbursts without provocation, hypervigilance, recklessness or self-destructiveness, individuals get easily startled, impaired concentration, and sleep disturbances. The symptoms must last for more than 1 month, and other medical conditions that can cause them should be ruled out. Acute stress disorder causes many of the same trauma-related symptoms as PTSD, but a key difference is that the symptoms last at least 3 days and up to 1 month following exposure. Like PTSD, individuals must have either directly experienced a traumatic event, witnessed it in person as it happened to others, only heard about it but it involved a close family member or friend, or they must have experienced repeated or extreme exposure to graphic details of traumatic events. Second, at least 9 symptoms from the 5 main symptom categories need to be present at the same time. To recap, that includes intrusion symptoms, either distressing memories, nightmares, flashbacks, psychological distress or marked physiological reactions, anhedonia, dissociative symptoms like an altered sense of oneself, avoidance symptoms like avoiding distressing memories and thoughts or external reminders, and finally arousal symptoms, which include sleep disturbances, irritability, hypervigilance, impaired concentration, and an exaggerated startle response. Third, there are adjustment disorders, which are a group of disorders marked by maladaptive emotional or behavioral symptoms that develop in response to a stressor. For example, some individuals might be rebellious or anxious, while others might feel sad, hopeless, or powerless after a divorce. First, for diagnosis, the symptoms should appear within 3 months after the stressor and should disappear within 6 months. Second, the symptoms should cause significant impairment in social, occupational, or other areas of life. And lastly, the disturbance should not meet the criteria for another mental disorder, like depression, or be an exacerbation of a pre-existing mental disorder, like anxiety that worsens after a divorce. Next, reactive attachment disorder is a rare condition in which infants or young children don't get attached to their caregivers. The symptoms appear following the lack of adequate care or negligence, and should be evident in a young child between the age of 9 months and 5 years. First, children must withdraw from caregivers, rarely seeking comfort when distressed and not responding to caregivers that comfort them. Secondly, children must show persistent social and emotional disturbance characterized by at least 2 of the following 3 symptoms: minimal emotional or social bonds with others, limited positive affect, and lastly, episodes of unexplained irritability, sadness, or fearfulness even without being provoked. Third, these children either have experienced social neglect or haven't felt adequate comfort, stimulation, and affection from caregivers, have had repeated changes in primary caregivers which prevent stable attachments, especially common in the foster care system, or have lived in environments that severely limit opportunities to form attachments. The disturbance shouldn't be accounted for by a developmental delay, which typically has an intellectual disability, or by an autism spectrum disorder, where there isn't usually caregiver neglect. The 5th condition is disinhibited social engagement disorder, a condition that appears mostly in infants and children that have experienced neglect in the first 5 years of life. And as in reactive attachment disorder, the children should have experienced either social neglect or deprivation of affection from caregivers, repeated changes of primary caregivers, or grew up with few opportunities to form long-standing attachments. The first criterion is disinhibited behavior towards strangers, described by at least 2 of the following 4 behaviors: having no reluctance in approaching and talking to strangers, having an overly familiar verbal and physical demeanor, not checking back with the caregiver after venturing away, and being willing to go off with a stranger without hesitation. For example, these young children might approach a complete stranger on the street, have a small chat, and then sit on the stranger's lap. Second, the symptoms should include socially disinhibited behavior and not just impulsivity. Now, if an individual meets some, but not all of the criteria for any of these disorders, and they have a specific symptom that stands out, then they can be diagnosed with other specified trauma and stressor related. If there isn't a specific standout symptom, then they might get the diagnosis unspecified trauma and stressor related. When it comes to treating trauma and stressor related disorders, there are 3 main approaches: psychotherapy, lifestyle changes, and medication. First, there's psychotherapy, which typically takes place weekly for about 90 minutes over 8 to 12 weeks, but can be extended for those with significant comorbid disorders or social problems. In PTSD and acute stress disorder, trauma-focused cognitive behavior therapy is effective regardless of the amount of time that has elapsed since the trauma. It can include a range of cognitive behavioral interventions, including exposure therapy, where people confront traumatic memories in a safe environment until they feel distress, in vivo exposure, where individuals gradually confront the situations, people, or places that they have been avoiding due to the associated distress, and cognitive therapy, which addresses unhelpful beliefs and assumptions associated with the trauma. Eye movement desensitization and reprocessing, or EMDR, is another type of psychotherapy that involves individuals moving their eyes back and forth across the field of vision while recalling traumatic memories. The technique has evolved over time to incorporate aspects of cognitive and exposure therapy, and it's especially helpful in post-traumatic stress disorder. In adjustment disorders, cognitive behavioral therapy can be combined with psychodynamic psychotherapy, which helps individuals become aware of their thoughts and decisions and their influence over their lives. In reactive attachment disorder and disinhibited social engagement disorder, treatment approaches include play therapy and expressive therapy, which help children form attachment through multi-sensory processes that include games and art. Next, lifestyle changes can also make a difference and improve treatment effectiveness. Moderate physical activity, 30 minutes on most days of the week, can improve health and reduce stress. Exercise can also provide a much-needed break from difficult emotions and distressing memories and can improve feelings of self-control and help with self-esteem. Studies show that having a regular sleep schedule and doing yoga are specifically helpful at managing anxiety symptoms and sleep disturbances. In addition, creating a regular daily routine can be a powerful stress and anxiety reducer, increase serotonin levels, and can also act as a positive distraction. There's growing evidence that a healthy diet rich in foods with high levels of magnesium, probiotics, and zinc might also help reduce anxiety. For example, that could be done with leafy green vegetables, pickled foods, and nuts. Avoiding alcohol, drugs, and high-sugar food and drinks can also help improve symptoms like alertness and hypervigilance. Many communities have support groups for survivors of trauma, which can help individuals build a strong social support system. In reactive attachment disorder and disinhibited social engagement disorder, making the child feel safe is a priority. One way to do that is to make sure that parents don't fight in front of the children, that they have fun activities that they do together, and that the children's emotional needs are promptly met. Having a predictable routine and schedule, a healthy diet, and plenty of exercise can also help bring stability into their lives, which also helps. Finally, there are several medications that can help improve symptoms for some trauma and stressor-related disorders. Exceptions are reactive attachment disorder and disinhibited social engagement disorder, for which there aren't any indications for medication. SSRI antidepressants like sertraline, usually 25 mg orally once a day, and escitalopram up to 20 mg per day, can help with anhedonia, concentration issues, and dysphoria. Sometimes atypical antipsychotics like clozapine can be used in conjunction. If effective, oral medication should be used for at least 6 months to a year to prevent relapse or recurrence. Because there's a high risk of treatment failure, it's essential for individuals to keep a good track of their symptoms and self-monitor symptoms through scales, interviews, and journals, so that they can reach out for help proactively whenever symptoms reappear. Also, families should be educated alongside the individual to spot changes in behavior and to reduce relapses. Alright, as a quick recap. In PTSD, the symptoms must last for more than 1 month, and they include exposure to trauma, intrusion symptoms, avoidance behavior, negative alterations in cognition and mood, and alterations in wakefulness and reactivity. In acute stress disorder, the same symptoms are present, but they should last at least 3 days to 1 month following the traumatic event. In adjustment disorders, there are maladaptive emotional or behavioral symptoms that develop within 3 months of a known stressor and resolve within 6 months. Reactive attachment disorder is a rare condition in young children between 9 months and 5 years old, where they don't get attached to their caregivers due to a lack of adequate care or negligence. Disinhibited social engagement disorder is when young children show disinhibited behavior towards strangers following neglect from caregivers. For PTSD and acute stress disorder, trauma-focused cognitive behavior therapy is recommended once a week for 12 weeks. In adjustment disorders, cognitive behavioral therapy can be combined with psychodynamic psychotherapy. And in reactive attachment disorder and disinhibited social engagement disorder, treatment approaches include play therapy and expressive therapy. Lifestyle changes that help are regular exercise, a healthy diet, having a schedule, and a support system that can make the individuals feel safe. When it comes to medication, antidepressants can help in treatment-resistant cases, and in extreme situations, an antipsychotic can also be added. Oral medication should last for at least 6 months to a year to prevent relapse or recurrence.
A 31-year-old female named Amelia comes to the mental health clinic complaining of trouble sleeping due to vivid nightmares recounting an armed bank robbery she witnessed 4 months ago. Ever since that event, she has avoided going to crowded places that remind her of the bank to the point where she had to give up her job at the mall. Suddenly, your phone starts ringing and Amelia jumps from her seat. You apologize, and she then mentions that this happens whenever she hears sudden or loud noises. Okay, based on the initial presentation, Amelia seems to have some form of trauma or stress-related disorder. Many individuals at some point in their lives experience trauma, which can be thought of as a distressing event that causes an overwhelming amount of stress, exceeding one's ability to cope or process the emotions caused by that experience. Trauma can be caused by one single event, such as a serious car crash or sexual assault or abuse, or can last for a more prolonged period of time, such as experiencing poverty, neglect during early childhood, or military combat. Most of the time, with support from loved ones, individuals are able to recover from a traumatic experience. Unfortunately, some individuals may develop trauma and stress-related disorders, where traumatic experiences lead to symptoms like flashbacks, nightmares, and anxiety, all of which can interfere with day-to-day activities like working, studying, eating, and sleeping. Now, the underlying cause of trauma and stress-related disorders is poorly understood, but what you need to remember is that individuals affected usually have altered levels and response to stress hormones like adrenaline and cortisol. For your exams, the most high-yield trauma and stress-related disorders are post-traumatic stress disorder, acute stress disorder, and adjustment disorder. Okay, let's start with post-traumatic stress disorder, or PTSD for short. This usually occurs in individuals who have either directly experienced a traumatic event or witnessed as it happened to others, but it can also affect someone who just heard that a close family member or friend was involved. In a test question, make sure to also keep an eye out for someone with prolonged or extreme exposure to graphic details of traumatic events, such as a police officer or paramedic, as well as a military veteran. Now, symptoms of PTSD must last for at least 1 month, and they mainly include recurrent, involuntary, and intrusive memories of the traumatic experience through nightmares or flashbacks. When exposed to physical or mental reminders of their trauma, these individuals typically experience intense psychological distress or physical reactions, such as sweating and heart palpitations. For your exams, what's important to remember is that this may cause them to feel a sense of hypervigilance, meaning that they are constantly on guard, as well as hyperarousal, where they have this exaggerated startle response to the smallest of triggers, such as sudden or loud noises. Another high-yield fact is that individuals with PTSD may start avoiding environments and situations that remind them of their trauma, such as certain places, activities, or even other people. Finally, thinking and mood might be negatively affected, so individuals may have exaggerated negative beliefs about oneself, others, or the world, like thinking the world is completely dangerous and no one can be trusted, or persistent negative emotions such as fear, distress, or shame. Moving on to acute stress disorder, this also occurs in individuals who have either directly experienced or witnessed one or repeated traumatic events, or heard about it through a close family member or friend. Acute stress disorder causes many of the same trauma-related symptoms as PTSD, but a key difference you need to remember for your exams is that the symptoms only last between 3 days and up to 1 month following the traumatic event. Last but not least, there's adjustment disorders, which are a group of disorders that occur after an individual goes through a stressful or life-changing event, to which they have a hard time adjusting or coping. Now, events can range from a divorce or losing a job to being diagnosed with an illness. Individuals with adjustment disorder typically present with emotional symptoms such as anxiety, depression, feeling hopeless or powerless, and even suicidal ideation, which can lead to behavioral symptoms such as an aggressive or rebellious outburst. Now, keep in mind that, to diagnose an adjustment disorder, these symptoms must develop within 3 months of a known event and disappear within 6 months after the event has been resolved. If symptoms persist for more than 6 months, it is diagnosed as generalized anxiety disorder. Now, when it comes to treating trauma and stress-related disorders, there are 3 main approaches: psychotherapy, lifestyle changes, and medication. Milder forms of anxiety usually do not require medication. Instead, they can be managed by psychotherapy, including cognitive behavioral therapy, or CBT for short. This is a type of talk therapy that primarily focuses on teaching the individual strategies to address and cope with negative beliefs, assumptions, or emotions associated with their trauma. In addition, individuals may benefit from lifestyle changes like having a regular sleep schedule and a healthy diet, as well as meditation, deep breathing exercises, physical activity, and yoga. If these treatment approaches fail, there are several medications that can help improve symptoms. Now, first-line medications typically include selective serotonin reuptake inhibitors, or SSRIs, such as fluoxetine, paroxetine, sertraline, citalopram, escitalopram, and fluvoxamine, as well as selective norepinephrine reuptake inhibitors, or SNRIs, such as venlafaxine, duloxetine, and desvenlafaxine. In addition, prazosin, an alpha-1 blocker, may help with nightmares. Bear in mind that the exception is acute stress disorder, for which there aren't any indications for medication. Alright, as a quick recap, both PTSD and acute stress disorder can occur in individuals who have either directly experienced or witnessed one or prolonged traumatic events, or heard about a traumatic event that involved a close family member or friend. Symptoms include recurrent, involuntary, and intrusive memories associated with nightmares or flashbacks, as well as intense psychological distress or physical reactions, hypervigilance or hyperarousal, avoidance behavior, and negative alterations in thinking or mood. What sets PTSD apart from acute stress disorder is that in PTSD, the symptoms must last for more than 1 month, while in acute stress disorder, they should last at least 3 days, but less than 1 month following the traumatic event. In adjustment disorders, there are emotional or behavioral symptoms that develop within 3 months of a stressful or life-changing event and resolve within 6 months. Treatment of trauma and stress-related disorders typically includes cognitive behavioral therapy and lifestyle changes. If these treatment options fail, individuals can be treated with medications, such as SSRIs, SNRIs, and less commonly prazosin. Okay, back to our case. Amelia is a 31-year-old female that has been experiencing sleep disturbances due to vivid nightmares. A very important clue here is that her symptoms began 4 months ago, after witnessing an armed bank robbery. In addition, since then, Amelia has been displaying avoidance behavior related to crowded places that remind her of the traumatic event. This, along with her hyperarousal symptoms, such as jumping at sudden or loud noises like a phone ringing, make this a pretty straightforward case of post-traumatic stress disorder.
The ear can be broken down into 3 sections. The first is the outer ear, which is the part you see, called the pinna, as well as the ear canal. Next is the middle ear, which is a tiny chamber that houses the tiny ear bones, the malleus, the incus, and the stapes. And finally, there's the inner ear, which has very special tissue structures called the cochlea, which converts sound waves into electrical impulses for the brain, and the semicircular canals which help with balance. Between the outer and middle ear is an eardrum, also called the tympanic membrane, so no air passes between the 2 areas. But the middle ear does have another possible outlet, called the eustachian tube, which acts like a valve connecting the middle ear to the nasopharynx. This tube has 3 main functions: equalizing pressure across the tympanic membrane, protecting the middle ear from reflux of fluids going up from the nasopharynx, and clearing out middle ear secretions. Eustachian tube dysfunction describes situations when one or all of these functions aren't happening normally. In an adult, the eustachian tube is a roughly 4 centimeter long part bone, part cartilage canal that's surrounded by 4 key muscles: the tensor veli palatini, the levator veli palatini, the salpingopharyngeus, and the tensor tympani. And it's those first 2 that help a lot with opening up the tube. Actions like chewing, swallowing, and yawning all pull on these muscles to help open up the eustachian tube. The first and most common type of eustachian tube dysfunction relates to a problem equalizing pressure across the tympanic membrane. And a classic example is on an airplane. As the plane rises, the air pressure decreases. Since the middle ear chamber is a closed environment, its pressure stays relatively high and the tympanic membrane can start to bulge a bit into the outer ear. That increased middle ear pressure pushes a tiny bubble of air down the eustachian tube and into the nasopharynx, where it gets breathed out. This is sort of like what happens with a burp, where a bubble of air slips through the esophagus to relieve pressure. In fact, sometimes there's a popping sound that can be heard, like an ear burp. Through this process, the middle ear and the outer ear balance out their pressures. The reverse process happens when a plane lands, since the air pressure on the ground is relatively high, and the middle ear pressure is relatively low because a tiny bit of air was burped out. The volume of air in the middle ear shrinks a bit, creating a slight vacuum, and it can cause the tympanic membrane to bulge a bit into the middle ear. Again, a small bubble of air can slip into the middle ear to help bring up the pressure and balance things out. Now, in eustachian tube dysfunction, the tube might not be open because of a functional reason. The most common one being that a cold or allergies cause the tube to be swollen and full of secretions, which block up the passageway. Rarely, there might be an anatomical reason as well, like a large tumor or scarring in the eustachian tube from long-standing inflammation. Regardless of the cause, difficulty balancing out pressures can cause pain from stretching of the tympanic membrane, as well as make the ears feel plugged and muffled. And if the inner ear gets affected, it can also cause problems with balance. The next sort of dysfunction is when the eustachian tube allows chemicals and bacteria to get into the middle ear. This sometimes happens when individuals are born with eustachian tubes that stay open most or all the time, rather than being structurally built as valves. Other times it can happen in infants and children who naturally have short, floppy eustachian tubes that also don't do a good job of preventing substances from refluxing back into the middle ear. This can be a real problem when there's a lot of positive pressure on the nasopharyngeal end of the tube, which happens with crying and blowing your nose. Finally, the third sort of dysfunction happens when the eustachian tube and the tiny cilia within it are unable to clear out middle ear mucus secretions. Sometimes this can result from toxins like cigarette smoke, which damage the cilia, so that they can't flick back and forth normally to move the mucus. The dysfunction can also be associated with systemic conditions, like cystic fibrosis, which causes secretions to get really thick. Regardless of the cause, stagnant secretions can get infected, leading to more complications like otitis media, an infection of the middle ear. Treating eustachian tube dysfunction is done by relieving the underlying issue, the most common being a simple upper respiratory viral infection, or allergies which can improve with decongestants and sometimes a short course of steroids. In some cases, tympanostomy tubes are surgically placed between the middle and outer ear, creating a direct opening between them to allow pressures to equilibrate more easily. Alright, as a quick recap, the eustachian tube connects the middle ear to the nasopharynx, and is useful for equalizing pressure across the tympanic membrane, protecting the middle ear from reflux and clearing out middle ear secretions. Eustachian tube dysfunction affects all these functions and can cause pain, muffled sound, balance problems, and can also lead to infections like otitis media. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.